Good morning, everyone. Sorry for a little delay, a couple of minutes late. Good morning. Okay, please turn your cameras on.
Professor, I have an appointment today, so I will be here, but I won't have my camera on during the whole session for class.
Oh, for the whole session?
Yes.
Okay. There's some students still showing absent here. Let me know if you're here. Abhijit, Vishal, Taylor, Stephanie, and Rabia.
I just logged in, sir. Michelle.
Okay, thank you.
Professor, I also just logged in for Taylor.
Okay, you did? All right, Taylor. Thank you.
Hello, Professor. I just logged in as well.
Thank you, Stephanie. Excuse me. Just refreshing my page. So I still show Abhijit, and Rabia. These are the two students showing absent. You guys have any questions or anything while we're waiting for the students to hopefully join soon?
Professor, I
Oh,
think Avi is logged in. He might just be having trouble with his course key because he sent a message on the chat.
yeah, he said he's going to be an hour late because he has a family emergency.
I'm sorry, who?
Abhijit. So he said he'll join around 9:45 to 10, but he has a family emergency right now.
Okay, because I didn't get any message, but thank you for letting me know. Okay, anybody heard from Rabia? Harjot or someone else, could you please drop a text for
I did,
Rabia as
Professor,
well?
but I didn't
Okay.
get anything back. Yeah.
Okay, thank you. Quick moment. Okay, give me one quick moment, guys. Okay, my apologies. Sorry about that, guys. I just had to make a quick call. All right, so let's move on. Rabia, are you here?
Good morning, Professor. Yes, I'm here. I am scanning in the code right now.
Okay, please do so that we can move.
Done. Thank you.
Okay, thank you. Okay. Okay, let's start the first chapter of the day. So today as well, I believe we have 3 chapters to cover. And do you guys realize any different today? Anything different? Or anything special today? What is different than previous lectures? Excuse me.
It's our last lecture.
Yeah, as far as the chapters will be done today. No more chapters. Okay. See, do you guys remember the day we started? And here we are now. Go so quick. Right? All right. Kristen is happy. Okay. But remember, we still have these 2.5 weeks to work hard. Because now we have to cover the whole material. All right. Let's start our lecture, guys, and wrap this up. Do. Okay. There you go. So the first chapter today is dermatology, okay? Topical products, dermatology. We'll talk about skin conditions, then dermatology drugs, which one uses for what, and then any specific, unique interactions, things to watch, which are important when you're taking care of your patients who are using these drugs. So first of all, when we talk about dermatology products, we're talking about something applying topically on the skin. So we need to know first about skin. So skin is the largest organ of the body, and so there are many essential functions it plays. Now, as far as the layers for your skin, there's outer layer, which is called epidermis, and then is your dermis, which is your middle layer, and then hypodermis, which is the subcutaneous layer. So epidermis, the outermost, the function of your outermost layer is protecting against environment. So it's a barrier from bacteria, chemical, UV radiations. It has something called keratinocytes, which produce keratin and giving the skin strength and water resistance. Okay. And then also there are melanocytes, which produce melanin to protect against UV damage and the skin, its color, the color to skin. Also plays an important role in water retention and preventing any excessive loss of fluids. Well, I'm sorry to ask, you guys can see my screen, right? Yes? Okay.
Yeah.
Thank you. Derm is the middle layer. It provides more like a structural support to the skin through collagen and then elastin fibers, which gives it strength and flexibility. So this layer also contains blood vessels, which nourish the skin and also help regulating the body temperature. Then there are sweat glands, which helps in maintaining the body temperature called thermoregulation by producing sweat, which evaporates and cools the body down. Then there are sebaceous glands. They produce oil, which is called sebum, the oil. And the function is lubrication and waterproofing the skin. And then there are nerve endings in the dermis, which help sensing any touch, pressure, temperature, pain, and it sends a signal, and then brain sends the response. Like if you touch the hot surface, then it transmits the signal to the brain, and the brain tells pull away. And then hair follicles. They're also located in the dermis and helpful in thermal insulation and then also sensory function. Now, your hypodermis, the subcutaneous layer, it provides a cushioning to protect the underlying muscles and organs. It also stores fat. The fat serves as a source of energy and also provides insulation to help regulate body temperature. And this layer contains larger blood vessels as well as nerves, which help maintain the the skin's metabolic needs. Now, if somebody asks you what are the functions of the skin, just pick up what I just shared with you. Number one, your protection as a physical barrier, right, against mechanical injuries, pathogens, microorganisms, and harmful chemicals, protecting against the UV radiation, right, which melanin plays a role. Temperature regulation through your sweat glands, and also dilating the blood vessels to release heat while constricting blood vessels to conserve more heat to maintain the temperature. Now, sensation. So nerve endings in the skin, they detect any touch, pressure, vibration. So these are the sensors. Excretion. Okay, to some extent plays a role in immunity as well because it contains some cells called Langerhans in the epidermis. So they play a role in the immune system by detecting the foreign particles, the invaders, and activating the immune response. Also, synthesizing vitamin D from sunlight. And then a barrier, water, preventing excess loss of moisture, dehydration. Uh, so these are primary functions of skin. Uh, let's watch this real quick. It should be short. Okay.
Starring two chocolatey treats on a stick.
Oye, can I borrow your gummy eye?
What for?
The skin, or integument, has many important functions in the body. It provides protection, acting as a barrier against injury or trauma. For instance, if you cut your finger, the skin barrier helps to minimize the damage to underlying structures. Dendritic immune cells in the epidermis signal an immune response against foreign invaders that have entered the skin. Melanocyte cells, located in the epidermis, produce the pigment melanin in reaction to exposure to ultraviolet light. This protects nuclear DNA in cells in the skin and also protects internal deeper body tissues from being harmed from the UV rays. The skin is important in metabolic regulation as keratinocyte cells synthesize or produce vitamin D3 due to exposure to ultraviolet radiation from the sun. This increases the absorption of calcium and phosphate in the small intestine, which are both important for bone health. As little as 10 to 15 minutes of exposure to direct sunlight per day provides the body with sufficient vitamin D3. The skin also functions in secretion and absorption. When body temperature rises, the body discharges substances from the skin in sweat. Sweat consists of water, salts, and a nitrogen substance called urea, which is the cellular waste product. The skin can also absorb certain chemicals, for instance nicotine from nicotine patches. The skin also plays a role in temperature regulation. If the body is cold, blood vessels in the dermis can narrow, which is called vasoconstriction. This diminishes the amount of blood flowing through them, causing a person to look paler. The body does this to conserve heat. The blood vessels in the dermis can also increase in diameter, called vasodilation, allowing more blood to flow through them. This allows the body to lose more heat if it's too warm. A person may appear to look more pinkish or reddish in this situation, and this can be seen during exercise as the body attempts to lose heat. The skin functions in sensory reception as tactile corpuscles located in the papillary layer of the dermis are touch receptors that detect cold, vibrations, and pressure. The skin also provides strength and flexibility as the collagen fibers in skin give it its strength, and the elastic fibers allow the skin to stretch and recoil so the body can move in multiple directions without tearing the skin. And that be the major functions of the skin.
Okay. This is again same information what we just talked about. The functions of the skin. Right? Providing protection, temperature regulation, sensation, excretion, immunity, vitamin D synthesis, a barrier for excessive water loss, all those things. Okay. Now let's talk about some conditions, common conditions, as well as the solution for them, how to treat them, what medications. So There are bacterial, fungal, viral, different type of infections. Um, the bacterial skin infections, they are caused by the bacteria. So technically we use antibiotics for them, right? For fungal, we use antifungal. For viral, we use antiviral. There are different skin disorders as listed here, like your folliculitis, impetigo, phrenicle, carbuncle, cellulitis, and all that, and usually caused by your strep, which is Streptococcus pyogenes, and then Staphylococcus aureus, called staph infections. And then very common medications, topical medication used for these conditions are bacitracin, and then your polymyxin, neomycin come individually as well as in combination. Also, not only these two, along with steroid as well. And then mupirocin, Bactroban, it is also used, especially there's a nasal product which is used for treating nasal colonization of MRSA, MRSA. That's also important to know. Here's your bacitracin, very common, which is a topical antibiotic used to prevent the bacterial infection in case of minor cuts, scrapes, or burns. What is the mechanism of action? Well, it inhibits the bacterial cell wall synthesis. That's the mechanism of action. It is mostly effective against the gram-positive bacteria, your staph and strep. Okay.
What was the method of action again? I'm sorry.
The mechanism of action?
Yeah.
It inhibits the bacterial cell wall synthesis.
I also have a question.
Mm-hmm.
You said nasal colonization of MRSA. Which drug was that?
Mupirocin, Bactroban.
Thank you.
Yeah, I'll mention it again. It's going to come again. But that drug is important, especially for that condition. This is ODC product, very commonly used. It comes in combination with bacitracin as well, like cream, ointment. We call like triple antibiotic. So that's a combination of your neopoly and then bacitracin in that. Your neomycin is an aminoglycoside antibiotic, and it works by inhibiting the bacterial protein synthesis, and mostly targets the gram-negative, some gram-positive. Polymyxin, that's a peptide antibiotic which disrupts the cell membrane of gram-negative bacteria. You don't have to go much in details about these, okay? Okay, here's important drug. Vishal, this is here again, okay? Mupirocin, that's the one we're talking about. Right name Bactroban, mupirocin. Now this is used on the skin, topical product, and this is important for which type of infections? Staph, which is staphylococcal, and streptococcal, impetigo. That's a skin infection. And second important thing is the intranasal form. The nasal formulation is used to treat the nasal colonization of MRSA, MRSA. Excuse me. And what was the topical use for on the skin? For your staph and strep infections called impetigo. 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 So these two things are very important for this drug, okay? The ointment or the cream topically on the skin, what it's used for, and then what the nasal formulation is used for. That is important about this drug. Any questions so far?
Yes. Is this all we have to know about Bactroban?
Correct.
Okay, thank you.
Excuse me. Okay, here's another very important drug, silver sulfadiazine or Silvadene. Now, what is important about that? Well, number one, that it is an antibiotic, anti-infective. What this is used for? And the answer is burn patients, the patient who has burns. Very important. Number two, if you read the name again, silver sulfadiazine, sulfa, it is a sulfa drug. So if any patient allergic to sulfa drug, you should not give this medication to that patient. Okay? Now, third important thing, and it is related to the first, which I mentioned, that what type of patients it's used in burn patients. So in burn patients, more specifically, if you talk about, it is used for mostly second and third degree burns, which are your partial thickness burns, as well as which impact the dermis, which is the lower layer of the skin. And then full thickness burns go through the dermis, affect the deeper tissue down there. So this is pretty much it about this drug. So used for burn patient and for second and third degree burns. And then it's a sulfa drug, should not be used in patients who are allergic to sulfa drugs.
I have a question.
Yes.
About this. It says to treat infection. So if someone has a second or third degree burn, you don't always put it. It's just only if they're at risk of an infection, or do you just put it just as like
It's usually used in order to prevent and treat.
Okay. Okay.
Because the patients with those that deeper burns,
Mhm.
they're at a very high risk of getting that infection. It's real quick. So this is used in order to prevent from happening, and if someone has it, to treat.
Okay. Yeah, so it's not like for wound healing, right? It's just
No,
for
no. It's not.
Yeah, okay.
It's not wound. It's technically it's more for infection. It's not.
Infection, yeah.
But
Okay.
wound could result from infection, but the purpose is to prevent the infection.
Okay, thank you.
Okay, you're welcome. So this drug kind of works by disrupting the bacterial cell wall and inhibit its DNA replication. Okay. Now, one of the most common problems, acne, acne, acne. Okay. There's several type of acnes, as you see on here on the PowerPoint, the slide. Blackheads, whiteheads, and blackhead, whitehead simply are named based on how they look. If the top part, the head is black, they call it blackheads. If it's white, they call it whiteheads. Well, they didn't call the papules the redheads, right? They could have, but it's different. So their papules are small red bumps. Then if there's pus filled in there with that yellow top on it, it's called pustules, named based on pus filled in there, pustules. Okay. And nodules. Nodules are larger, but you cannot see the pus on top. It's inflamed, but when you touch it, it's kind of hard. It's quite hard. On the other hand, the cyst, they are softer because there's pus filled in there. And the nodules, it's more inflammation. Okay. Your whiteheads, they are more like the pores clogged with oil and dead skin cells, and then covered by a thin layer of skin. So they're small, flesh colored, or maybe a little white. Then the blackheads, as I said, they're clogged pores where the surface remains open, And the material inside, it oxidizes and turns into black. And then the others, like papules, pustule, nodules, those are more like inflammatory ones. Okay, I'm going to show you a little quick video, and then we'll move on.
At PG&E, we're adding more safe and affordable renewable energy every day. We're deploying new technologies.
Hello everyone, welcome to Let's Shoot. Our topic for today is a problem for all. Who wants that red bumpy skin? All of us want clear and spotless skin, isn't it? Except for our childhood days, acne is a problem for all age groups, right from teenage to adulthood. Acne knows no discrimination, be it male or female. But in today's session, let's deep dive and understand few things about acne, like the science behind it, why it occurs, the difference between a pimple and acne. So stay tuned with us till the end, as the video will definitely benefit you. So to begin with, what is acne? Acne is a skin condition that is triggered because of three things: excess oil, clogged pores, bacteria on the skin. Let's understand this better. The skin has sebaceous glands present right under its surface. The main function of this gland is to secrete an oily and waxy substance called sebum. It coats, protects, and moisturizes the skin. Depending on the level of sebum secretion, your hygiene, and climatic conditions, there are three types of skin. Dry skin. Here the sebum secretion is less. Normal skin, where the sebum secretion is at the required quantity. And oily skin, where excess sebum secretion is seen. Acne is mainly an issue with oily skin types. The hair follicles present under the skin routinely shed dead skin cells along with sebum. But when the body produces extra sebum and dead skin cells, they are not completely shed. Instead, they stick together and block the tiny pores. This results in skin blemishes. This encourages the growth of bacteria in that region. There are bacteria that are naturally present on the skin and are harmless, but under favorable conditions, they flourish, leading to inflammation and spots. You can see a bumpy appearance and red to pink color around it. Now, depending on the location of the clogged pore and inflammation, acne may appear as one of the following. Whiteheads. They are clogged pores close to the air. If the clogged pores are exposed to air, it turns to form a darker color and appears as blackheads. If the clogged pores contain pus in them and are highly inflamed, we call them pimples or pustules. But if the clogged pores are larger, pus-filled, and located deeper in the skin, we call them cysts. So by now, could you figure out if pimples and acne are the same? No, they are not. Acne is a disease, and pimples can be one of the symptoms. So by clearing that misconception, we end this session. Hope the session was informative, and if you like,
Okay, guys, hope I give you a little bit of information in just a different format. Now, as far as the solution for this problem, let's talk about that. Anti-acne drugs. So they target different underlying causes of acne, such as excessive oil production, bacteria, inflammation, or the clogged pores. And let's talk about that. One of the most common OTC product, benzoyl peroxide, which is the starting point. So it kills the acne-causing bacteria and help reducing the production of oil as well. Used in mild to moderate acne. So it releases oxygen, and this bacteria hates it. They can't survive in that oxygenated environment and they die. Then there's salicylic acid, which kind of exfoliates skin and unclogs the pores by removing the dead skin cells. It helps in both black and white heads. Then there are antibiotics, such as clindamycin, minocycline, erythromycin. These are the most common one used. Then there are retinoids, which has tretinoin, isotretinoin, adapalene, which are your vitamin A derivatives, and that isotretinoin carries a high risk. I'll share that information with you. Then there are some oral treatments as well, which includes your tetracycline antibiotics, such as tetracycline itself, your doxy and minocycline. These are the most common used. Then in females, you will come across your hormonal methods, your birth control pills, oral contraceptives are given to improve the acne symptoms as well. Okay. So this is another way I put it on, and just to give you an idea how, like adapalene, which is different gel, it's a vitamin D derivative. Then there's azelaic acid. This is called benzaclin, which is a combination of benzoyl peroxide, an OTC product, and clindamycin, an antibiotic. So kind of comes in a powder form in a small container, and the pharmacy mixes it with water before dispensing it to the patient right when they're picking up, and then it's usually good for like 30 days. Then tretinoin, which is retin A gel, also where it's a vitamin A derivative, and benzoyl peroxide and OTC, which is usually where people start with. And then these oral contraceptive. This is how they look like. This is your benzoyl peroxide, and this is benzaclin, which is a combination of benzoyl peroxide and clindamycin. This is your tretinoin, and this is azelaic acid and adapalene. Now, a drug which I shared here as well, your isotretinoin, which is highlighted. So I want you to know one thing about it. This drug is contraindicated in pregnancy, okay? So if a female patient of reproductive age, if they are using this medication, it is essential to educate the patient to use 2 forms of contraception while they're taking this medication. Very important, okay? Do not miss that. 2 forms of contraception while your patient, female patient, is taking this medication. Usually what happens is when they go to the doctor, so every month they have to go there. You cannot get a refill on this prescription. Every time it has to be new prescription. So they go to the doctor's office. Doctor's office performs pregnancy testing. Then there's a system called iPledge. These patients usually have like a green card with them, a card similar to medical card, but it's green in color. That's why they call it green card. They take it to the doctor's office. They bring it to the pharmacy. Now the doctor's office, whoever is responsible, they go to that iPledge system, enter the information on their end, and then there is an authorization number they provide. So when the patient comes to the pharmacy needs the authorization number, then they enter the information, enter that doctor's provided authorization number, and then they get an authorization number from the iPledge system, a new authorization, which they have to enter in their system in order to bill and get that approved. Okay, so that's the process of getting prescription for these patients who are reproductive age. That is very important, okay? Now it's
Professor,
good
is
to,
this
uh-huh.
sorry, is this specifically for the isotretinoin or is that for all acne medication?
Isotretinoin only.
Okay.
Now, educate your patient to apply it properly, okay, in the right manner. So it's always good to educate them to apply it when they can provide enough contact period for that drug to be effective, right? Usually at nighttime, Tell them to wash the face, clean, pat dry, and then wait for a little while to dry the skin out, and then apply. Not just kind of rubbing on hand and then try to apply it. Make like little tiny spots all over, and then gently kind of let it absorb. Not vigorous, you know, and then let it stay for about 30-40 minutes, and they can apply a thin layer of like a moisturizer on top, and they can take it off in the morning. And same way every day. Here comes your oral drugs. Your tetracycline antibiotics, these are the most common used in acne. It comes in various forms. These comes as what I showed you here. These are peel forms, and then there are also topical forms. Clindamycin, erythromycin, that come in your topical forms, and these tetracycline, doxycycline, minocycline, as I said, they are the most commonly used. But in some patients, you may see Bactrim, which is sulfamethoxazole trimethoprim combination, and erythromycin as well. Okay. Any question? All right. Here comes important information about tetracycline antibiotic. Make sure you know that, please. They are contraindicated in pregnant patients, not in pregnancy. Now, the reason behind them is, and also children below the age of 8 years, they can permanently stain their tooth. So during pregnancy, they can do that even to the fetus. So permanent stain on tooth. So that's a big no-no. Other important thing is, I don't know if you remember that or not, when we're discussing the antibiotic chapter and we're talking about these tetracycline. Tetracycline should not be given with any dairy products or antacids or iron, because they will form an insoluble bond with tetracycline antibiotic, flush them out without letting them produce any therapeutic effect. You guys remember that? Okay. Yeah, that is extremely important. Okay, do not miss that part. So somebody, pizza, there's cheese, milk, that kind of stuff, yogurt, not with tetracycline antibiotic. Your patient, pregnant, no. Kids below the age of 8, no. Moving to the next problem, the topical, which is your fungal infection. Now, fungal infections are caused by fungus, right? So often, affecting the moist, warm areas of the body. There are different type of fungal infections, such as tinea and tinea, based on the location on the body. That's how they're named. Let me give you some example. And these are also important to know, so please note them down. Tinea pedis. Pedis mean on the foot. It's also called athlete's foot. Tinea pedis. So affects usually the feet. Then tinea corporis, which is your ringworm infection, as seen in the picture. Ringworm. It forms kind of in ring, circular ring, red and kind of scaly patches on the top. And then tinea curaris. Okay, CRURAS. It's called joke itch. Okay. Now, important to know are the locations. Okay, for this, like cruris, this affects the groin area. Okay, know that. Next is tinea capitis, CAPITIS, which is on the scalp. Okay, and then the unguem, the tinea unguem, these are the one which affects the nail. Know the location of each one. Okay.
Professor, can you please repeat those again?
Yeah. So tinea pedis is the athlete's foot, which is the location is the feet. Okay. Tinea corporis, it could be everywhere else on the body. If you compare it with the tinea curaris, which is only in the groin area, but the corporis, it could expand to other areas. And then tinea capitis is on the scalp, and unguem, that is the one which affects the nail. And there's a candidiasis, which is caused by the Candida albicans. Um, then there's a tinea versicolor. There's a different type of it. It's a yeast which affects the upper body and causing like a discolored patches. It could be like pink, white, brown with mild scaling on it. So the drugs used, they are the antifungals. So such as your topical antifungal, which are very commonly used, and there are several which are available OTC, such as your clotrimazole, miconazole, and it comes in various forms. Not only topical. Now your clotrimazole, for example, very commonly used for your athlete's foot, joke itch, the ringworm, and yeast infection. Similarly, your miconazole, ketoconazole, they're pretty much the same. They belong to the same class. And then there are terbinafine and a few others. There's a nystatin and cyclopyrox. These are cyclopyrox. Then there's a tolnaftate. These are for more stubborn fungal infections, prescription, and usually the treatment goes on for a long time. It could from months to maybe a year or two, who knows? But these are some of them are hard to treat, especially under the nails. Okay. Let's talk about the fungal infections. Fungal. Okay. So these are caused by fungus, and the drug we use, they are antiviral drugs. Antiviral. Most important, acyclovir, Zovirax. Acyclovir. Very important to know. Acyclovir can be used to treat the first episode as well as any recurrent episodes of both HSV1 and HSV2, which is your herpes simplex virus 1 and herpes simplex virus 2, as well as HPV, the human papilloma virus. So herpes 1, oral lesion, herpes 2, genital lesions, and then HPV. So know that this is the drug of choice. Everybody clear? Understood? Any question? Always make sure that you provide appropriate education. For example, here, the patient might think, oh, I got the medication, so now it's going to fix everything. It, will cure this. Antiviral does not cure anything. What they do is antiviral. If you remember what we talked about when we're doing the antibiotic chapter, antivirals, they reduce the duration by blocking further replication, right? Further replication. So it reduces the duration and severity in symptom, but it does not cure. Okay. Now, suppose a patient got injured, has a kind of a cut somewhere, maybe on hand or somewhere, and it needs the stitches, right? Now, when they do so, well, it's a needle. And that's why going through that, it's like swing, right? So that hurts. So what you need is a local anesthetic, not a general, local anesthetic to apply just in that area where the workable area is, wherever they're going to work, in that area, so that you can numb that area for a little while and perform that procedure. So those are your anesthetic drugs. Numb the surface of the skin. And it's a temporary numbing for any minor procedures or to temporarily providing pain relief. Now, common ones like your lidocaine, benzocaine, prilocaine, tetracaine, they end in cane, C-A-I-N-E. Okay, C-A-I-N-E, canes. So somebody has a cut, injury, or even insect bites, severe sunburns, poison ivy exposure, these things could be painful. Then there's a cream. It's called EMLA. It's got a eutectic mixture of local anesthetics, which has lidocaine, prilocaine. It's a combination product, very commonly used in your dialysis patients. And anybody seen the fistula where they make that area to put the catheter in? Has anybody seen that? Anybody ever seen?
I've seen it.
Can you describe that? How does it look like?
The one that's in the arm, it
Mhm.
just looks bumpy. You can't take a blood pressure on it.
Yeah, it's bumpy because they need inlet outlet, so they make it there. The blood vessels, they kind of connect it there, and those needles, um, you know, catheters for dialysis, the needles are huge. They're very painful, and to insert that and minimizing that pain, discomfort during that, they use this EMLA to numb that area for the time being. Got it? Okay. Here are the antipruritic simple words for itching. Okay, pruritus is itching. So anti-itch. These are your antihistamine for the starters, for less severe. And if it's super crazy, might be corticosteroids alone or along with antihistamines can be used. Because all these reactions, like when itching happens, so technically body is releasing histamine in response to that foreign intrusion. And antihistamine block that, and the corticosteroids also suppress that immune response. So you'll see these hydrocortisone, triamcinolone, all those creams given for those severe conditions. And usually, if it's for the face, the strength is low, and if it's the body, it's higher strength. And then for calming effects, it could be aloe vera. gel, it could be calamine lotion. Those things could be there as well, or menthol. And then diphenhydramine, which is your antihistamine cream, right? These are most commonly used. Here's another condition when there's lice infestation, pediculosis, that's also it's called, so infestation of lice, which can affect different parts like scalp, head lice, body lice, or pubic area, pubic lice. And there are several medications available, such as permethrin, very commonly used. This one right here. So comes in lotion, cream, and this is the first line treatment for head lice. Quite tricky to treat. You may have to do multiple treatments and using that a special comb to kind of pull everything out, including the eggs and everything, and repeating it, and also kind of washing the clothes in real hot water, or kind of putting it in a polythene bag and just close it for a couple of weeks and those kind of things. Then there
which one was the head lice one? Which one was the head lice one?
permethrin.
Permethrin.
Yeah. Then there's malathion. This is also for head lice. And then ivermectin, which is also topical lotion. It's an antiparasitic, which paralyzes and kills the lice. There's a spinosad called Natroba. Linden is there. So there are multiple products available. Now, as far as hair loss, okay, hair loss, to some extent, in some patients, and just FYI that it doesn't work for me, okay? I haven't even tried. I know it's not going to work. I lost too much already. So with hair loss in male and female, it should be used if somebody's pregnant, but normal, healthy adult. This minoxidil, which comes as Rogaine as brand name, and then there oral finasteride, which can also be used in patients, usually males more, and it should be avoided, not only avoided, actually, it's a contraindicated and it's a pregnancy category X in females, okay? Finasteride. Minoxidil, what it does is, when you apply, it usually comes in like a foam. You kind of apply on the scalp and let it sit there. It helps dilation of blood vessels. So when the vessels are dilated, then more blood flows to that area and kind of help the hair grow. That's what the concept is. But this drug can drop patients' blood pressure as well. Not in everybody, I mean, but there is risk. Okay. And as I said, the finasteride, it's a pregnancy category X, should not be used during pregnancy. Aloe vera is another natural plant extract, commonly used for like soothing, and somebody has some sort of skin irritation, it can kind of soothe. Then as far as nursing implications, what are important? Sorry, give me a sec. Okay. It's just a repetition of information which we talked earlier. Isotretinoin, not in pregnancy, And it should be monthly pregnancy testing and 2 forms of contraception. Number 3, monitor the liver functions while they are taking this medication. This is all what you need to know about isotretinoin. Some drugs, as we just talked about a minute ago about your Rogaine, right? So it can dilate blood vessels and drop patients' blood pressure. So consider that any medication, even though you're applying it topically, but to some extent, even though less, might be systemically absorbed as well and can produce systemic effects. So just watch, be careful for those. And when either you're applying or patient applying, make sure you educate them that wear gloves. Don't apply with bare hands any of the drugs. And then also, as a nurse, you should document everything. For example, somebody has burns and you applied silver sulfadiazine. You got to measure that area, okay? How big that is, wide that is, the dimensions, anything, if there's a wound, how deep is it, and then the color around there, is there any inflammation, is there any pus? So all those aspects, those should be documented. Okay, and what type of patient response you see in there? Is it improving? Is it same, getting worse? So that we can make changes in the care plan. And when there is an irritation, something sensitive, make sure you protect it from direct sunlight because it'll get more irritated. And if somebody has wound, burn, and you use some sort of dressing in there, make sure you're not throwing it in the regular bin. Should be properly disposed. Educate the patient what to expect in regards to your therapeutic effect as well as the adverse effect. Okay, any questions? No question? Okay. Let's do a couple of questions and then we'll take a break. Okay, let's see. Good job, proud of you guys. Very well. Okay. So the correct answer is C, mupirocin or brand name Bactroban. Okay, okay, and okay. Good job. Okay, let's read this question. Perfect, perfect. Great job, guys. Once again, the correct answer is C because isotretinoin, number one, is pregnancy category X, and if somebody's taking it, it must be monthly pregnancy testing and 2 forms of contraception. Good job. Okay, let's look into this question. Right, good job. Well done, well done, well done, well done. Yes, yes, and yes. Absolutely, everybody answered correctly, which is B, silver sulfadiazine. Okay. What severity level of burns are they used for?
Second
Second
and
and
third.
third.
Yes, excellent. Good job. All right. Okay, perfect. Yes. B is the correct choice. Acne vulgaris, that is the bad guy here. Good job. Okay. Perfect. Yes, great. A is the correct choice. Candidiasis. That is the fungal infection because it's an antifungal. Perfect. All right. Another one. Great. Yes. Once again, it's A. Bacitracin is an antibiotic. Antibiotics are used only for bacterial infections. Okay, perfect. Okay, let's see if you can identify. This is a little tricky one. Oh, wow, great. Okay. Great. Yes, guys. A is the correct answer option. Tinea curaris, your ringworm. And if you remember, tinea pedis was on the foot, tinea curaris in the groin area, tinea corporis is on the other parts of the body, and tinea capillaris is on the scalp. All right, we are done with this chapter. You guys ready for a break?
Yep.
Yes. All right, so it's 10:08. You can take 12 minutes, okay? Let's come back at 10:20. See you guys shortly. Okay, welcome back, everyone. Let's turn the cameras on.
Professor, I joined late, but I'm here now.
All right. What time did you come in, sir?
10:20ish.
Is everything all right?
Yeah, I had to do some stuff with my grandpa. None of my parents were home, so I had to take him to his appointment.
Okay. Okay, you're checked in. Okay, you guys still see my screen? Still there? Not disappeared?
We can still see it.
All right, thank you. Excuse me. So let's move on to our second chapter of the day, the ophthalmic drugs. So we'll talk about the conditions of the eye and the drugs used for them. Few important things we're gonna discuss, which are a little unique. Any contraindication interactions and important aspects when you're taking care of your patient who are using any of the ophthalmic drugs, what kind of important points for your nursing care plan. Now, here are a few terms here. I want you to know them. They are important, such as mydriatics, miotics, cycloplegics. Now, let me make it simple for you. The top two, mydriatics and miotics. Which one is the longer word?
Mydriatics.
Mydriatics. So that one is bigger, is going to dilate the pupil of the eye, make it bigger. The second one, miotics, is the shorter one, so it is going to constrict the pupil. Clear? Understood? Just remember that word. Longer the word is, the bigger the pupil it's going to make. Shorter one is going to make it small. Okay? The third one, cycloplegics. Plagia, it means you're paralyzing it. So these are for temporary paralyzing that area topically or locally there in order to do something. For example, somebody got injured, like eye injury, and you have to numb it, paralyze for somebody in order to perform any surgery, or there's an object you need to remove it. So in those situations, you kind of paralyze that area, as well as some of them are used for dilated eye exam, the open eye exam where they can see it well. And usually when they are used, the doctor tells you, like, they give you like those cheap uh, glasses. You've seen like those kind of like paper, the plastic things, the cheap glasses to put on for some time after a dilated eye exam, because the pupils are wide open and then it hurts when you go out. Okay, so now let me give you some examples. For example, mydriatics. Now, as I said, dilate the pupil. They dilate the pupil. Example, your phenylephrine. Phenylephrine. So used in the eye exam to allow better viewing of the retina and other structures inside the eye. They can also be used before the eye surgeries, okay? Also for certain some conditions as well. Now, the issue with them is just temporary, I would say, that eyes become very sensitive to the eye. Oh my goodness, I'm flipping again. Okay, sensitive to the sunlight, okay? Comes sensitive to the sunlight. And it can cause blurry vision for some time. Now the miotics. Example, your pilocarpine, carbachol. They are the cholinergic agents and they cause constriction of the iris. What is the use? Most commonly for glaucoma. Because remember, anticholinergic makes you slow, sleepy, drowsy, dry. Now these are cholinergics. Cholinergics makes you wet. So means the outflow is increased. And remember the problem with glaucoma? Increased intraocular pressure because the outflow is less. So these drugs increase that. In some surgeries as well, you will see that. Not much of adverse effect. Same thing for some time, blurry vision. Then cycloplegic example, your atropine, very commonly used. So temporarily paralyzing the ciliary muscle so that eye does not try to accommodate and kind of try to focus, and also dilating the pupil. Used in these eye exams. Okay. My goodness, people text you anything. I don't know. Somebody's asking, where are we meeting for dinner? People have so much time. Okay, guys. Now, you may come across patients which are using only one type of eye drops. On the other hand, you may have patients using multiple eye drops. If your patient is using only one type of eye drops, make sure if it says 5 drops, you just don't, just spill it there. Make sure that it's drops, and if it's it doesn't happen quite often. Usually it's 1, 2 drops or like that. Then you can put those drops. But if something is say like there's a certain condition of surgeries or a severe conditions, it may say like 10 drops. But you don't want to flow it up. You probably want to instead of what can be absorbed as just not flushing, dropping down right away. And if there are more than one eye drops, space them out by 5 minutes. That's very important to know and educate your patient. More than one eye drop, space them out by 5 minutes. Now, there are different eye conditions and drugs you use to treat, for example, for glaucoma, for bacterial infections, any inflammation in the eye, anesthetics probably for some short amount of time, maybe during surgeries. Then there are diagnostic drugs, for example, the atropine for those dilated eye exams, and then your allergy medications when eyes are watery, itchy, red, and then lubricants and moisturizer with the people who has dry eyes. Okay, like Visine and those ones available. Glaucoma. Glaucoma. Important to know what is glaucoma. Well, you can simple words say hypertension of the eye. The pressure becomes too high. Pressure is high, and that can damage the patient's optic nerve and they can lose their vision. There are 2 types of glaucoma, okay? Open angle and closed angle. Closed angle is a medical emergency. Sudden onset and very high risk, the patient should be in the hospital. On the other hand, open angle Means the outflow is there, but it's not enough, and it's causing pressure in the eye, and that's where the maintenance medication goes on. Same condition, and that's also important, guys. If same condition, the glaucoma, present in an infant, it's called congenital glaucoma. So note that down as well. If we talk
Can you
about
repeat that one more time?
yeah, congenital glaucoma, if it's in infants. Excuse me.
Can you please repeat which glaucoma, open angle or angle closure, was the one that's immediate emergency?
Yeah, I'm going over that now again, okay? So open angle and closed angle. Open angle is the most common one, less severe. Okay, there is risk still, but it's less severe. Closed angle, they also call as angle closure. It's the same thing, closed angle or angle closure. This is the acute glaucoma, which is a medical emergency, and the patient should go to the hospital. Let's talk about the difference. Now, in open angle, the drainage canals in the eye, they become gradually, slowly, over time, becomes clogged and increase the pressure in the eye. So usually patients are asymptomatic in the early stages, and it can lead to gradual loss of peripheral vision. And not treated can lead to blindness. On the other hand, angle closure glaucoma or closed angle glaucoma or acute glaucoma is a medical emergency. It's less common, but it's very high risk. Now, when does it happen? When the iris is kind of pushed or pulled forward, blocking the drainage angle completely. The drainage canal is completely blocked now. The patient will experience sudden extreme pain in the eye, headache, nausea, blurry vision, and they may see like, hollows and kind of lights flickering. And this can cause severe vision loss. Okay. And you may see another type called normal tension glaucoma. Even though the eye pressure levels seems normal, but there's a optic nerve damage. Usually in patients who has a family history of glaucoma, with cardiovascular conditions, or patients with low blood pressure. Those are some patients could be at high risk of developing a normal tension glaucoma. And as I mentioned earlier, congenital glaucoma, it's a rare form of glaucoma which occurs in infants. And that can happen because the drainage system in the eye did not develop properly. And those babies may have enlarged eyes or cloudiness and kind of very sensitive to light. In order to diagnose, there are certain things, for example, the ophthalmoscopy that is examining the optic nerve for the damage, and then tonometry, which measure the intraocular pressure in the eye. They can also do the field test and that kind of stuff, for gonioscopy, which is examining the drainage angle of the eye. So medications are used either to decrease the production of aqueous humor, you can say the water in the eye, and try to visualize it. Let me actually go to the next slide. So this is the normal eye, okay? Normal eye. And this is with the glaucoma. What happens here is that drainage canal here, that gets clogged, okay? Gets clogged. Here, it's draining. It's draining here. Goes in, it's draining. But here, it gets clogged, and now the draining is not happening, and that water, or technical words called aqueous here, it starts building up pressure and can damage the optic nerve, which is responsible for vision. You guys understand the concept? What the problem is? Now let's talk about the solution. What does these drug do is two things, okay? Two things. Number one is that it decreases the production of the aqueous humor. Second, it increases the outflow. And some drugs does both. Like there are eye drops, which are under category or classification of beta blockers. They does both. Decrease production of aqueous humor as well as increase the outflow of aqueous humor. I'm going to show you a quick video and then we'll move forward. I just want you to understand the condition well.
Glaucoma is actually a group of eye diseases that are usually due to intraocular hypertension, or increased pressure in the eye, which damages the optic nerve and, if left untreated, can lead to blindness. Taking a closer look at this cross-section of the eye, you can see that it's split up into different chambers. The anterior chamber includes the area from the cornea to the iris. The posterior chamber is this really narrow space between the iris and the lens. And then this larger vitreous chamber includes the space between the lens and the back of the eye. Not to be too confusing, but both the anterior and posterior chambers are located within the anterior section of the eye, while the vitreous chamber is part of the posterior section of the eye. Typically, each of these chambers is filled with fluid. The chambers in the anterior section are filled with a liquid called aqueous humor, and the posterior section is filled with vitreous humor. The aqueous humor is a transparent, watery fluid that's secreted by the ciliary epithelium, which, in addition to secreting aqueous humor and providing nutrients to the lens and cornea, it provides structural support and helps to keep the shape of the eye. So that fluid's secreted into the posterior chamber, and then flows through a narrow space between the front of the lens and the back of the iris, through the pupil to the anterior chamber. From there, the fluid flows out of the eye through the trabecular meshwork, which is a spongy tissue that acts like a drain. And this allows the fluid to go down into a circular channel called the canal of Schlemm, and finally into the aqueous veins, which are part of the episcleral venous system, the veins around the sclera of the eye. In glaucoma, part of this aqueous humor drainage pathway becomes partially or completely blocked, so that fluid can't easily drain out. This causes the pressure within the fixed space of the anterior chamber to quickly build up, causing intraocular hypertension, which is defined as pressure greater than 21 millimeters of mercury, or 2.8 kilopascals. This high pressure affects all the structures of the eye, including the optic nerve, which is the nerve that carries visual information from the eyes to the brain. And this means that over time, as the optic nerve gets damaged, glaucoma leads to vision loss. Now, there are a couple types of glaucoma. First, there's open-angle glaucoma, which is actually the most common, and it has this name because the angle between the cornea and the iris is open. In this type, the drainage system slowly gets clogged over time, and so there's this gradual increase in pressure on the optic nerve. This increase in pressure initially results in atrophy of the outer rim of the nerve, resulting in a decrease in peripheral vision. As that pressure increases even more, though, there's continued damage to the optic nerve, which eventually leads to a loss in central vision as well. Another type of glaucoma is closed-angle glaucoma, also known as angle closure glaucoma or narrow-angle glaucoma. And this is due to the angle between the iris and the cornea being too small, meaning that the passageway for aqueous humor outflow is too narrow, and this is as a result of the lens being pushed against the iris. The result of this is that the drainage system gets blocked again, but this time causes a rapid buildup of pressure within the eye, which can cause abrupt onset of severe eye pain, eye redness, blurry vision, headaches, nausea, and visual halos. Finally, normal tension glaucoma, or low tension glaucoma, happens when the pressure is normal in the eye. The cause of normal tension glaucoma is largely unknown, although it's thought that the optic nerve becomes damaged due to hypoperfusion, or poor blood flow, as well as potentially genetic hypersensitivity to pressures that are even in the normal range. For diagnosis of glaucoma, tonometry can be used to assess for increased intraocular pressure. Also, though, visual field testing can be done, as well as looking for optic nerve damage, either through imaging or by direct observation. In particular, that pressure on the optic nerve results in a thinning of the outer rim of the nerve, which starts to give it this cup shape, and this is called cupping, and it's often seen in individuals with glaucoma. Even though glaucoma is not curable, it can be slowed with treatment. If the underlying issue is intraocular hypertension, then it can be managed by taking medications that decrease the pressure in the eye. This can be done in a couple ways. First, by decreasing the production of aqueous humor with medications like beta-adrenergic receptor antagonists and carbonic anhydrase inhibitors. Also, though, you can increase the outflow of aqueous humor by taking prostaglandin analogs. Or finally, some medications both decrease production and increase outflow, like alpha-adrenergic agonists. In addition to medications, there are also laser treatments available. For example,
Okay, I'm gonna skip the laser treatment, guys. Okay. I hope you were able to understand what the issue looks like and how we're trying to fix it. So once again, this is the open angle, this is a closed angle, this is a red alert. Okay, and it happens all of a sudden. Sharp pain in the eye, and this develops over time. Now, if you heard, you just mentioned in the video, the different drugs used, and one of them, and I said that as well, beta blockers, such as timolol, very common, timolol. Make sure you know that, and you educate your patient that it has to go on that medication. It's not for a week or a month or so. That they may have to take it all along. Okay, so educate, do not stop it without consulting the doctor. They may say, oh, I don't have that pain in the eye anymore. I don't feel anything. I'm good. Well, good because you're using the medication. So you cannot discontinue. Okay. And these beta blockers, as I mentioned earlier, they not only decrease the production, they also increase the outflow. All right. So here's some drugs. Let's talk about them one by one, okay? One by one. Here are cholinergics. Cholinergics. Cholinergics makes wet, means it increase the level of secretions. Outflow increased. They stimulate the parasympathetic nervous system, which leads to effects such as constriction of the pupil, miosis, and increased aqueous humor outflow. Examples such as pilocarpine. Pilocarpine. You may see it for both type of glaucoma, open and closed angle. And then another common, carbachol. Carbachol is another one. Then there are other one as well, like ecothiopate, iodide, and others. This is how they look like. So this is carbachol, this is pilocarpine. Once again, these are direct acting cholinergic, and then ecothiopate, that is indirect acting. Okay. Adverse effect. I'm not worried much about it, except I would say a couple drugs or classes, classification. Their adverse effect, if there are any, they're usually local. Within in the eye itself, maybe mild, kind of either redness, itching, or watery eyes. Other than that, not much of a concern. For some drugs, such as beta blockers, okay, timolol is a very common drug used as an eye drop for these conditions. What is the use of beta blockers in general? What they do?
Lower blood pressure.
Lower
Or
blood
vaso.
pressure.
Yeah.
Yeah. So anytime use beta blocker, no matter in what dosage form, either it's topical, oral, or in the eyes, ophthalmic drug, the drug's properties never change. So its property is to drop the blood pressure. So make sure you instruct your patient, educate your patient how to properly use it and what to do to prevent systemic absorption in the body, because that can drop the blood pressure. Okay? And the method is like when you tell them, okay, lift your head up, pull the lower lid, and then drop. Once they put whatever the number of drops, 1 or 2 drops, tell them now what to do. See this part, your eye and nose junction here, both sides. Tell them to use a finger and a thumb. Apply a pressure for 1 full minute. Apply the pressure where? Inner canthus. It's called canthus, inner canthus. Do you know why? The reason I just told you. To prevent systemic absorption, because there are ducts. These are connected. Your ear, nose, throats are connected. Side, okay? So it can travel through the canal and be systemically absorbed into bloodstream. So in order to prevent that absorption, you tell the patient to apply pressure on inner canthus for 1 full minute. I see this question on NCLEX many times. Okay. All right, now, okay. So acetylcholine, direct acting, it's just the same drugs written here. So I'm going to go over to next slide. Okay, sympathomimetic drugs. So they mimic or produce a similar effect to what the sympathetic neurotransmitter, such as your appy, norappy does. Appy and norappy does. What is the use? Once again, the problem is too much pressure, and they reduce the pressure. So they reduce the intraocular pressure. Which condition? Glaucoma. Okay. Now, there are some examples here, such as brimonidine, very commonly used, which is your alpha-2 adrenergic agonist. Then there are dipivefrin. Let me actually show you. I think I have the picture here. There you go. Yeah. So this is your lopidine. This is alphagan, which is brimonidine, very commonly used. The mechanism of action is that they stimulate the alpha-2 adrenergic receptor in the eye. What it does is it decreases the production of aqueous humor. As I mentioned previously, the drugs works in 2 ways here. One, they reduce the aqueous humor production, or they increase the outflow, and some drugs does both. And this one, I would say primarily decrease the production of aqueous humor. Right? Guess that's pretty much it for that. Now they're telling us what they're used for. We all know for glaucoma. That's what we use it for. Adverse effect, I'm not worried much about them, guys. So, but for these drugs, I will. Okay, beta adrenergic blockers or beta blockers. Once again, for what condition? Glaucoma. Which problem we are fixing? High intraocular pressure. How does it work? How does it reduce? So they block the receptor called beta receptor, beta adrenergic receptor in the ciliary body of the eye and reducing the production of aqueous humor. It also increases the outflow. Okay. Now, as I said, these are beta blockers, ends with LOL. Timolol is one of the most common one used, reduce aqueous humor production as well as increasing the outflow. That is important for us to know. And what I just shared in the while we had the previous slide on, that apply the pressure to prevent systemic absorption. So very important for this class of medication. And know the mechanism of action as well. Okay. Any questions so far, guys? Any question? No?
What was the mechanism of action? I don't know if you already said that.
Okay. So remember in simple words, okay? Remember in simple words, because you know that they block the beta receptors. That's what you know. But here we need to know from what specifically they do here with the eye related to the problem. The problem is that increased intraocular pressure because of the aqueous humor, right? So they reduce the production so that there is less aqueous humor, reducing the pressure. And also the problem is that it cannot go out. So it increase the outflow so there is less back there. Make sense? Both ways it's supporting to decrease the pressure.
Oh, okay. Gotcha.
Okay. Anyone else, guys? Any other question? No? Okay. This is the same information, nothing new, guys. We talked about it. These are general effects, not much of concern for me, but this is what the timolol looks like. And once again, what is important about them is number one is what is the mechanism of action? Decreasing the production of aqueous humor and increasing the outflow, resulting in a decreased intraocular pressure. Everybody clear about that?
Can you say it one more time? I'm sorry.
Yeah. As I mentioned earlier, relate to the problem. The problem is higher pressure in the eye because the build of aqueous humor, simple words, the water in the eye, not outside, in the back, and as well as inability to flush it out. So it's not going out completely, not as a tear. There are canals inside. I'm talking about that. Don't consider it as that, oh, that they had tears in the eye, they said the draining, not that, okay? It's the canals inside. So they're not able to drain. And these medication, they reduce the production of the trouble, the too much water. So now there's less aqueous humor, the water, reducing the pressure as well as because they were stuck. Now it helps to drain it out as well. So both support in reducing the pressure in the eye. So it makes sense? Is it clear? If your patient asks, I'm feeling better, can I stop it? You just say two words, N and O. No and no. Thank you. All right, no. That is important. Patient does that all the time. Oh, I stopped using it. I was fine. And if they're using more than one drop, once again, space out by 5 minutes.
Do you mean like one drop per bottle or like a different eye medication
Different
drop?
drug. Different drug.
Okay. So like one drop is basically what one like that's the serving size.
Okay.
I don't I can't think of the word right now.
Let me simplify. So patient has timolol and they have phenylephrine. These are two different drugs, two different eye drops. So if you're using timolol first, put it in, wait for 5 minutes, and then use phenylephrine. Make sense?
Okay, so two different meds.
Two different drugs means two different medications. Not multiple drops of the same drug. Is that clear now, or
Yes, thank you.
Yeah, okay. Alrighty, now another important class, carbonic anhydrase inhibitors. Carbonic anhydrase inhibitors. What these are? So they are also used in treatment of glaucoma, once again, addressing the problem to decrease the intraocular pressure. How? They reduce the production of aqueous humor. So this is important for you to know all these classes, that which one does what. How does it help your patient? Does it reduce the intraocular pressure by reducing the production of aqueous humor, or outflow, or both? All these drugs, whatever I'm putting on, please make sure you know which one is under what. You can write down on the top mechanism of action and then write some common names under that, and same you should do for the others, and just create a mnemonic and you will know that. Okay. These drugs ends with zolamide, like acetazolamide, benzolamide, or zolamide. They all end with zolamide. Here they look like, that's how they look. So your bronzolamide or zolamide. Once again, these drugs used for glaucoma by reducing the intraocular pressure. There are some oral forms as well. The next are osmotic diuretics, ocular diuretics. So they are used in acute conditions more, like the closed angle, but when you need a rapid relief in the intraocular pressure, you want it to reduce it quickly. How? They are diuretics. So they draw fluid out of the eye into the bloodstream. So from the eye into the bloodstream, they move it. So which is the acute problem? The angle closure or closed angle? Okay. So they pulls the water and move it into the bloodstream. That makes less in the eye and reduce intraocular pressure. Common example, mannitol. Usually in those emergencies, it's given IV. In which condition? Acute condition, a closed angle or angle closure. Then for, I would say, the more gentle side, generally that is glycerin. That is also an osmotic agent. And there's an oral osmotic agent, isosorbide. Okay, we talked about that, nothing new here. The spaceship, and this class is also important, guys. Prostaglandin agonists, they're also commonly used. Once again, to lower the intraocular pressure, how? Increasing the outflow of aqueous humor. This is a part of maintenance patients with open angle glaucoma, not the closed, open angle glaucoma. And once again, know the mechanism of action. It increases the outflow of the aqueous humor. These drugs ends with prost, latanoprost, bimetoprost, travoprost. They all end in prost. And I'm going to share something interesting about them. Make sure you know it. It's extremely important about these drugs. Anybody knows what it could be or anything you're aware about? Anything important about these eye drops? Anybody? No? All right, so let's know it. So there's a unique adverse effect with these, with all these prostaglandin agonists. The people who has colored eyes, okay, blue, dark brown, hazel, green. These drugs can change the color permanently to brown. So suppose your patient has increased intraocular pressure in one eye and you did not educate. Now one eye is blue, the other is brown. Think about it, what they're going to tell you. So please don't give this unwanted gift to your patients. You have to be very careful. Patients with colored eyes. So that is important to know. They test on these things all the time. Okay. Okay, these are your antibiotics. So somebody has an infection in the eye, bacterial infection, so that's where you use these ocular, ophthalmic, antimicrobial drugs. It could be your, antibacterials are for bacteria, and then antiviral for virus infections. For fungal infection, those are your antifungals. These drugs you will see. Now, if we go to the antibacterial, for bacterial infections, there are a few commons. Your erythromycin, your gentamicin, tobramycin, very commonly you will see them. And they come in otic, the eardrops as well. Same drug, but it's a different formulation. Can you use them vice versa, one another, if the pharmacy doesn't have one? Anybody knows?
I'm going to say no.
Okay, is there a reason?
Because you said it's a different formula?
No, I said it's the same medication, but it's one says eardrops, the other one says eye drops.
Wouldn't the concentration be different for, or no?
Let's simplify that. Let's have it in the same concentration.
Okay, then yes.
Yes?
Would they work on different parts? Like, are they specific to work on different parts? Like one specifically for the ear and it gets absorbed a certain way rather than the eye?
If it's the same drug, I mean, it has the same properties, but now let me tell you what, there's a slight difference. Suppose patient has ear infection, okay, ear infection, and the doctor wrote down the prescription for otic, means the eardrops, right? Now the patient goes to the pharmacy. They said, "Oh, you know what? We don't have this one. It's back order. I don't think we can even get it." Well, now what can we do? Well, we have the eye drops, okay, and you can use them. And a patient like, no, that's different. Well, eye drops can be used for ear in case if they don't have that one, but you cannot use the eardrops in the eye. Well, isn't that a little partial for the eardrops, right? The reason behind that is the eye drops are sterile products. They are sterile. They can be used in ears. Eardrops are non-sterile, and a non-sterile product cannot be used in the eyes. Does that make sense? Yes? Understood? Clear? Anybody still have questions? Eye drops are sterile products. Sterile products can be used at other places, but non-sterile cannot be used in eyes. And that is the whole reason, even though it's the same medication, eardrops cannot be used for the eyes. And your erythromycin, these are very commonly used along with the gentamicin, tobramycin. And when you look, your eardrops usually have OTIC, otic at the end. Okay. They also comes with, as you see here, dexamethasone, which is a corticosteroid. And these combination usually have dex at the end, like Ciprodex or like something like that, because that tells you that it has a corticosteroid along with an antibiotic. Okay. Ofloxacin is also common both ways, eyes and ears. Okay. Netamycin, this is used for your what you call the fungal infection, okay, for fungal keratitis. Then there's an off-label use from amphotericin B as well. There is a condition, okay, there's some conditions here like your blepharitis, conjunctivitis, and your keratitis. Blepharitis is more like an eye condition, very common, which makes your eyelid kind of red, swollen, irritated, and it's itchy and crusty dandruff-like flakes on it. And that's where it can be used. Then the pink eye, right? That is conjunctivitis, the pink eye, when the white part of your eye becomes kind of pinkish or reddish in color. And then keratitis is the inflammation of the cornea. Okay. These are your antiviral drugs as eye drops to treat viral infections. It could be from herpes simplex keratitis, and then also from herpes zoster ophthalmicus. And very common, your acyclovir. It can be eye drop, it could be oral as well, or combination based on the severity. Then there are like a trifluridine, which is here, as well as again cyclovir. Acyclovir is very common. Now, this drug, such as trifluridine, is used for a condition. It's called uveitis. It's highlighted here, and that is important for you to know, like what it is. So uveitis is a type of eye inflammation. It affects the middle layer of uvea, which is the tissue in the eye wall, middle layer of the tissue in the eye wall. And that's why it's called uveitis, the inflammation of the uvea. It kind of comes suddenly, has eye redness and the pain, and sometimes vision is blurry as well. It could be in one eye, it could be in both. Now, if your patient has inflammation in the eye, you need an anti-inflammatory. Okay, anti-inflammatory. So here comes the eye drops for reducing the inflammation. It could be because of conjunctivitis. It could be post-surgery. Surgery is a trauma, and whenever you have trauma, there is inflammation. So it can be used for a few weeks and usually gets discontinued. Diclofenac, ketorolac, these are the most common ones. I'm not worried much about any adverse effects other than just local kind of little burning, stinging, or itching, not more than that. And alone or in combination, you will see corticosteroids, the steroids, in those eye drops, as I said, alone or in combination. Once again, if you think when we're talking about steroids, in previous chapters, the main function of steroids is that suppress inflammation, and surgeries and all that, the patient, because of trauma, they experience inflammation. So, and then resulting in pain and other the symptoms. And these drugs can suppress those inflammatory responses. So your dexamethasone, prednisone, these are very commonly used. It could be inflammation, could be even allergic response. Patients may get option for these. I'm going to skip this. Here are some examples of your ophthalmic anesthetics to temporarily anesthetize, numb the area, either for diagnostic purposes or to perform a procedure such as surgeries, like your proparacaine, tetracaine, and once again, to identify them, look for cane at the end, C-A-I-N-E, they end with cane, and those are your anesthetics. And how they cause that numbness is they block the sodium channels in the nerve membranes. So technically, they are blocking the signal, they're preventing the nerve conduction. So they're not letting the signal pass and tell the brain what's going on. Now, these are your allergy drugs, anti-allergic, in form of eye drops. So it could be antihistamines or mast cell stabilizers. Your olopatadine, very common, a brand name Paranol or Paraday. Then there's cromolyn, ketotifen. These are also used commonly, but this olopatadine is very common. And here are some other drugs, like what I said, there's a phenylephrine, and this is very common, OTC products, your Visine. But look for, if it says Visine, because you may find more ingredients here, which has a different purpose, just than the allergies. It's the same name they see, but then there's something at the end, which indicates what they are for. Your patient may have dry eyes, and in order to address that concern, You may need OTC lubricants, or in severe cases when people are suffering from immunological conditions, then you may need stronger other medication, even immunosuppressant eye drops, to address that concern. Okay. Very common OTC drugs you will see for lubrication, but here, such as your, Excedra here, then there's cyclosporin, then there's lifitegrast is the generic for this Excedra. I don't know if you ever have seen that or not. Cyclosporin, the brand name comes as Restasis. Actually, I think I have it on next slide. Yeah, this is Restasis. So they're like individual single-use ampules here. You just kind of turn it, the top comes off, and still it, whatever left, just toss it. Single use, because you cannot close it back. So they suppress the immune response. That's cyclosporin. It's an immunologic drug for severe dry eyes. Then OTC are like usually carboxymethyl cellulose, also called like a CMC. And then there's a hydroxy propyl methyl cellulose, pretty much close to that, polyvinyl alcohol or polyethylene glycol or propylene glycol. These are usually OTC lubricant drops. But as I said, for extremely dry, severe immunological conditions, you may need these prescription Restasis, etc., those kind of medications. The nursing implication, when your patient are on these medication, number one is you need to assess any underlying conditions which can put your patient at risk. And if multiple drugs, as we said, separate them out. Now somebody asks you where to put the drug. Eye drops, like, is it like anywhere, whatever? The right way to do is, for example, if it's 2 drops or 3 drops, exactly the same number of drops into the conjunctival sac. It's called conjunctival sac, usually in the lower conjunctival sac. Okay, if they're laying down, that's fine. If they're sitting, then you need to tell them to tilt their head backwards. And then you pull the lower eyelid, that's conjunctival sac, that's where you drop whatever the number of drops are prescribed. And if it's ointment, eye ointment, then you apply a thin layer, once again, lower conjunctival sac. Okay, around the inside the eyelid, not outside, inside. And you tell them to close the eye and maybe move the eyelid, and that will spread around. Okay, any questions so far? Any question? Everybody's okay?
So eye drops and ointments, both conjunctival sac.
Conjunctival sac, yeah.
Okay.
Lower. What is it, Vishal? You're saying something?
Oh yeah, so both of them are lower conjunctival?
Lower conjunctival sac. And if it's an ointment, you tell them to close eye and kind of roll their eye. But if it's a eye drop, make sure after you install the eye drop, you're telling them to put a pressure in the inner canthus for 1 minute. And they ask why? To prevent systemic absorption of the drug. Okay. This we already talked about. Another aspect, guys. What if your patient wear contact lenses? Tell them to take them off. Okay. And then wear it after 15, 20 minutes at least. Okay. Another thing. What if it's one of those drugs which can stain, or remember they can change the color? So some of the drugs can stain the lens as well. So you may want to educate them to use like glasses during that period if it's one of those drugs. Okay. Let's do some questions and we'll take a break. Okay, let's do this. This is a common practice. Good job, guys. Wow, okay, nice. Excellent. Yes, you guys are right. Absolutely correct. C is the correct choice for Neisseria gonorrhea. You guys seen that? Baby's born and they just apply that? Newborn babies? Because of chlamydia, trachomatis. Prevention of eye infection in the newborns by Neisseria gonorrhea. Okay. Okay, this is a little tough. So you may have to do a little extra effort on kind of memorizing on these ones. Pilocarpine is a direct-acting parasympathomimetic drug used as miotic. B is the correct one in the treatment of open-angle glaucoma. Meiosis means constriction of the pupil, which increase the outflow. Okay, B is the correct choice. About next question. Should be an easy peasy one. Good job. Yes, B is the correct choice because you never wash anything first of all, especially with the tap water. No. Your eye products, including anything used, even dropper, sterile. Tap water while it's that. Okay. That was a quick catch, Jenny, NIT. Good job. Yes, guys. If you read the drug, sulfacetamide, sulfa always has high risk of adverse effects. And that is the reason if the patient is allergic to sulfa drug, it should not be given. Is that clear? Everybody understood? Okay. Okay, yes. Great work. Good job. D is the correct choice. Use of sunglasses because atropine will dilate the people. And now, if they go out without dark sunglasses, their eyes are going to hurt real bad. Okay, how about that? That is an easy one. Yes. If infant born with that condition, when they have increased intraocular pressure, it's called congenital. Technically, is any baby born with any condition, that condition becomes congenital. It's that simple. Okay. Okay. All right, let's just move on and take a break. It's 11:29. Sorry, 11:29. Let's come back at 11:40. Okay, 11:40. Hey, welcome back, everyone. Let's turn the cameras on. And let's complete the last chapter, guys. Okay. So this chapter is about ear drops or any other products used for ears. Okay. Otic drugs. So we'll talk about common conditions associated with the ear, as well as commonly used medication to treat those conditions. Any specific concerns or important aspects regarding your nursing care plan? So first of all, let's talk about the problem, and then we'll explore the solutions. So problem ear disorders, it could be related to different parts of the ear, from outer, middle to inner. Okay, so it can cause just kind of pain, discomfort, dizziness, and severe could cause even hearing loss. So outer ear, so it affects the ear canal and the external ear. And common ones, issues such as it's called otitis externa, means an outside. Okay, swimmer's ear. Swimmer's ear is common one, which is simply the infection of the outer ear caused by, it could be from bacteria, it could be fungal, and usually happens because of exposure to water. And the patient may experience pain, itching, swelling, and some discharge as well. And if it's an infection from bacterial agent, it could be antibiotic, or if a fungal infection suspected, maybe then antifungal. And also for pain, you may have those anti-inflammatories. Another very common condition, earwax, too much earwax, cerumen. So the drugs, ceraminolytics, or you can call them earwax emulsifiers or earwax removers. So we all have the normal process where the ear makes wax, but in some, either it gets dried out, gets stuck in there, so it's kind of clogged up, or some people just make a lot. Okay, they may experience some sort of discomfort, and then if it's for a long period, it could cause infection, inflammation, issues with hearing. They may feel like fullness in the ear, earache all the time, and then the drugs you can use, those earwax removal. One of the most common one, OTC or Dibrox, which is carbamide peroxide. Okay, and then if there's a foreign body objects like a beads or insect can get stuck, that's something else, a pain, hearing loss, and that has to be removed by a healthcare provider. Okay, and not that common though, but it could be infection of the cartilage of the outer ear, usually after an injury or piercing, and then they have redness, swelling, pain around that area, and then usually oral and or topical antibiotics can be used. And then as far as the middle ear, which is very common here, middle ear, it's called otitis media, which is common in kids, babies. Very, very common with babies. They can't explain what's going on. They're crying all the time. There's fever. They're tugging around the ear. They're pulling the ears. That's usually the otitis media, infection of the middle ear. And usually antibiotics are used along with pain relievers, fever reducers, Tylenol and stuff. more severe conditions like dysfunctioning of the eustachian tubes, when they have a blockage or malfunctioning of those tubes, which connects the middle ear to the throat, and where they experience a buildup pressure. And then decongestant or nasal steroids can be used in more complex situation then certain procedures could be performed. Then the eardrum rupture, which is tympanic membrane perforation, when there's a tear or hole in the eardrum, it could be because of injury or loud sound, or because of a severe infection. That requires, usually could require a surgery, tympanoplasty. Then for ear inner disorders, it impact the cochlea, which is responsible for hearing, as well as the vestibular system, which is responsible for balance. Okay, the condition, a known one is Meniere's disease, which is a disorder of inner ear. When there are episodes of vertigo, and they may complain kind of fluctuation in their hearing. Sometimes okay, sometimes can hear well. And then tinnitus, it's ringing in the ears. Or they're feeling that ears are full of something and a clot. And they experience vertigo, which is just a spinning sensation. It's like everything looks going around and around. That's vertigo. And the reason? Because it's impacting those ears. The ear, again, deeper the infection is, there you will see patients experience that balance issues. Okay. This is how your ear looks like, okay? This is how your ear looks like. This is your outer ear, that's your middle ear, and that's your inner ear. And that's what we're talking about. So outer ear, main function of your outer ear is to capture the sound waves and funnels them into the ear, right? You're just catching the sounds here, sending them in. That's what the purpose is. And there are different structures, such as your pinna, which is your auricular lobule, and then your external auditory canal, and then your eardrum. Okay, pinna is your visible part of the ear, which collects the sound waves and directs them into the ear canal. External auditory canal is the tube which carries sound from the pinna to the eardrum. And then eardrum, also called tympanic membrane, is a thin membrane which vibrates. It vibrates when sound waves hit it, and transmitting sound to the middle ear. This is your tympanic membrane, eardrum. Now, as far as your middle ear, that amplifies and transmits sound from the eardrum to the inner ear. Okay, and different structures which makes the middle ear, such as ossicles. Ossicles are like there are three bones. They're one of the smallest in the body, such as malleus, called hammer, incus, and stapes. Your malleus is attached to the eardrum, then incus connects the malleus to the stapes, and then stapes is the one which transmits sound vibration to the inner ear. And then your eustachian tubes, these, they connect the middle ear to the throat, helping to equalize the pressure on both sides of the eardrum, out and in. As far as inner ear, it converts the sound vibration it receives into electrical signals for hearing and maintaining balance. Now, what it is made of, number one, cochlea. So it is kind of, your cochlea, this one, the spiral shape. So spiral shape, there's a fluid inside. responsible for hearing. And there's a small organ called cordy, which has hair cells, which convert sound vibrations into electrical impulses sent to the brain via the auditory nerve. And then there is a semicircular canal. They are filled with fluid, which help maintain the balance. And they do so by detecting the head movements. And then vestibule, the central part of inner ear, which works in semicircular canals to maintain the balance as well. And then your cranial nerve 8, which is your vestibulocochlear nerve, which transmits sound and balance information from the inner ear to the brain. Now the key functions. Well, here, ear, we need to hear, right? Ear helps to hear. So hearing is what the purpose is, and as well as we talk about the inner part, also maintaining the balance. Now let's talk about the problems. Okay, once again, otitis media is real common, guys, okay, especially as I said in kids. It's an inflammation. It could be because of infection, okay? So infection or inflammation alone or both, or maybe one or another, of the middle ear. And as I said, in children, it's most common. When does it happen? When the area behind the eardrum becomes affected. Most commonly bacteria, but could be viral as well. When kids experience like upper respiratory infections, a cold and that kind of stuff, that's when you see this accompanying along with that. So there, it could be acute otitis media, sudden middle ear infection, painful. They have fever, and usually kids, they're really irritable, crying nonstop. And antibiotics are given during that time, along with fever reducer and pain relievers. Acetaminophen is given commonly. And then there's otitis media with effusion, means the problem because of fluid buildup in the middle ear. Even though there's no infection, but effusion, there's fluid buildup, and that patient feels that it's clogged. The ear is full of something. And most of the times it just resolves on its own. But if it's severe, the pain is there, and they're experiencing other systemic symptoms such as fever and all that, then they may receive prescription for antibiotics as well. Okay. Any questions so far? Any question? Anything, guys? No? Everybody's okay? All right, let's move on. Now, as far as the medications used, now based on the condition, what the problem is, we select the medication, right? If it's an infection because of bacteria, then we use antibacterial, like your regular antibiotics, such as ciprofloxacin, ofloxacin, and then your cordyspor and otic, which is a combination of neo, poly, and hydrocortisone. So neomycin, polymyxin antibiotic, hydrocortisone is a steroid, which helps suppressing that quickly. And if it's a fungal infection, we use antifungals such as your clotrimazole and stuff. If it's only inflammation, pain, then maybe anti-inflammatory or a steroid like hydrocortisone and stuff. Then there are analgesics, topical to put in ear, such as Oralgan, which is an antipyrin benzocaine, So it helps in pain and also numbs it and eventually helps in pain. Then for earwax removal, that carbamide peroxide, that's what most commonly used. So let's go over that information. Okay, first, antibiotics. Antibiotics, as I mentioned, Cipro, ofloxacin, Neopoly alone, or Neopoly with hydrocortisone. These are one of the most common ones used. Okay, and used in both otitis externa or otitis media specifically. Then antifungals. Actually, tobramycin, I forgot. Tobramycin is also common alone, as well as tobramycin plus dexamethasone. It's called Tobradex combination as well. Antifungal for fungal ear infections, such as your clotrimazole, fluconazole. In some patients, it could be given oral as well. And earwax removal. Now, this is also important. So know that carbamide peroxide, somebody asked you which one. Carbamide peroxide is the earwax removal most commonly used to soften and make it easy to remove the earwax. Okay. How does it work? When you instill the eardrops, it releases oxygen when it comes in contact with the earwax, helping it breaking down, soften it, so that it's easy to come out. Soften, loosen it. Then there's another one, hydrogen peroxide. Well, some people just kind of try to do it on their own. Shouldn't do that. That's not recommended. Okay. But that pretty much does the same thing, release oxygen and helps breaking down, soften it. Then I want to share a picture here. I believe the next slide. That is very important. I have seen a question being asked on this carbamide peroxide many times when they assess if you're able to figure out if patient comes to you, they're asking, what can I use for this purpose? Because it's a common condition. And you should know that's carbamide peroxide. And then how to actually use it correctly, especially in regards to different age groups. Okay. Does anybody know, like, what is the right way of using it? And what's the difference between when you do it in kids and adults?
With kids, you pull back and down, and then adults back and up.
Perfect. Right. Yeah. So this is what the picture shows. Now, let me give you a little tip here. Okay. Both patients, kid or adult, you have to pull it backwards, no matter what. Okay. Backwards both. So difference is in one you're pulling up, in the other you're pulling down. Now, in between adults and babies, who's taller? Adult. So adult, pull up. Who's smaller? Baby, pull it down. Okay. So back is for both. Adult, up and back. For babies, down and back. Clear? Understood? Just remember that. Very easy. If they ask you how to use it, well, look at the patient's age. This is another important factor. How do you determine at what age that you pull it down and backwards, or from what age group you start pulling up and backwards? Anybody knows?
Below 3, pull ear down and back, and above 3, pull ear up and back.
Excellent. Perfect. Thank you so much for telling that. That is absolutely correct. Below 3, down and back. Anybody older than that, up and back. All are clear. If to everybody, is this concept clear? Please let me know if it's not, because it is important. Anyone who is still not clear? Okay, I'm gonna show you this video real quick. It's what we talked about.
How to use eardrops properly. Wash your hands well with soap and water. Warm the eardrop bottle by holding it in the palm of your hand for a few minutes. This will make the eardrops more comfortable to instill. If instructed by your pharmacist or doctor, gently shake the bottle for 10 seconds. Remove the cap or dropper from the eardrop bottle. Make sure nothing touches it or the tip of the container. Tilt your head to one side or lie down with the affected ear facing up. For adults or children over 3, gently pull the top of the ear upward and backward. For children under 3, gently pull the bottom of the ear back and down. This will straighten the ear canal. Instill the correct number of drops in your ear, as instructed on your prescription label. Ensure that the dropper or the tip of the container does not touch the ear or other surfaces to avoid contamination. Keep your ear tilted up for 3 to 5 minutes. Replace and tighten the cap or dropper right away. Make sure not to touch the tip of the container or the dropper. Wash your hands to remove any medication. If you are instilling drops into both ears, wait 5 to 10 minutes between ears to allow the eardrops to run into the ear canal. Always follow the directions provided by your
Okay, I hope I
doctor
just
or
kind
pharmacist.
of explained it visually, same information one more time so that everybody understand it clearly. Now on the nursing implications, now ear is responsible to hear, right, for hearing. So anytime there is ear condition, you're giving them medications, what is important to monitor? Nothing?
Hearing loss, hearing improvement.
Hearing is important to monitor. Now, if somebody has a problem with the hearing, what are you expecting as a therapeutic outcome?
Hearing better.
Yeah, hearing better, improved hearing. All righty, all right. So always assess the baseline hearing so that you can compare. Assess any allergies or anything before giving them, anything which can put your patient at high risk, contraindication and stuff, proper administration, make sure patient understand, and if there is anything which can prevent them from using those medication, some drugs cannot be used if they have like any those the tubes and stuff and their ears, and certain can be used. So you have to make sure if it's safe to use. Now, very basic but important, right? Make sure that you warm the eardrops by rolling between your hands, not that, okay, let me warm it up in the microwave, right? Don't do that, please. Just roll it few times. That's it. And do not use cold eardrops. It will hurt. Cold eardrops, they will experience pain as well as issues with the balance. So no cold eardrops, now hot. Just warm by rolling it between your palms. Okay, if it's in the fridge, well, make sure you pull it out from the fridge, leave it at room temperature, I would say somewhere minimum 30 minutes to an hour. Okay. So one more time, how to administer. In adults, pulling up and back. In children below the age of 3, pulling down and back. And whatever the affected ear is, make sure that is up, not down, up. And leave it that way for about at least 5 minutes, if not more, because it's a topical product. For them to work, it has to stay in contact locally for enough. And if we're just getting up, raising our head, well, it's going to just flush out without producing desired effect. Here it says, I don't recommend it because usually patients have hard time drawing a line that, okay, which is the outside, and they just push it in. Saying small cotton, if it's you are doing it, or patient clearly understand outside means just outside. It's not just pushing it inside, just right there so that it's not draining out. But generally massaging the targus, this area can also encourage flow of medication if you do it here. That's pretty much it. Any question, guys? Any question? Okay. Now let's do some questions. Okay. Here you go. That should also be an easy peasy. All right, all right, all right, all right. So you answered D. That is correct. That is correct, because if you administer too cold, may cause vomiting, dizziness, all that. So it should be warmed. Where in the microwave? Yeah, for 10 seconds? Maybe 5? No? Okay, if you say so. All right, guys. Okay. Find the keyword. Good job, guys. Yes, D is the correct choice, because this is for patient's mother. Demonstrate the appropriate administration, the medication. Does everybody understand what angle we're touching here in the question? Or anybody didn't make sense? We're trying to target the nursing outcome for the mother. Okay? And the outcome depends on if she knows how to do it correctly or not. Okay. Once again, read it slow and find the keyword. Great job. Absolutely correct. D is the correct choice. The reason they may throw it up, ciprofloxacin in there as well. It's a combination cipro and dexamethasone as a ciprodex otic. But now they are pointing more specifically towards the steroid, what they do. And steroids reduce the inflammation. That is the reason we are selecting option D. Okay. Easy and busy. All right, excellent. D is the correct choice. Once again, what is the age? Below 3 and above 3. So this is 1 year, which is below 1. So down and back. Okay. Nice. Great, great, great. Perfect. You are absolutely correct. B is the correct choice. Carbamide peroxide, brand name Diprox. Generic is carbamide peroxide. Helps by releasing oxygen and help loosen it, break down so that it can come out. Some people, they have it kind of, really dried out for a long time. They may have to instill that few times and it may need provider's help to flush it out. Okay. Perfect. Yes. D is the correct choice. Okay. This we already talked about. Okay. Excuse me, guys. All right, perfect. Yes. Improved hearing is a therapeutic effect of OD drugs. Okay, perfecto. Oh, okay. Perfecto, perfecto, perfecto. All right, so chapter is done. Okay, here. All right, guys, can you believe we're done with all the chapters? All done. Yeah.
Just a brief question. So all the ear drugs we covered, they're all just pertaining to otitis media, correct? Like not the external ear or the inner ear.
So again, the difference is look at what condition you're trying to treat here. Now, otitis, it may have in some patient just kind of redness and a little inflammation, no fever, anything, that is something else, how you're approaching it. Now, with severe symptoms, now you may also uh, add that such as Ciprodex to suppress it quickly. But if it's just about removing earwax, that is different. So based on the problem, it's not about only infection, only about cleaning, the different conditions and different products. We are not generalizing it just for this purpose. Okay. And even the same condition, I mean, but based on the severity and the symptoms, your product may change. Anyone else? Any additional questions? Are you guys done creating your study guide? Yes, no, nobody yet?
Almost
Christian,
done.
it's almost done. Okay, how about others? How's everybody else doing? Please remember, don't take it as that you don't have an exam. That'll be the worst thing to do. Nothing worse than that. If we assume that it's okay, let's just take a little longer to create it. We have time. No. It's a whole lot of information which is not possible to learn well in 1 week. There's no way. So I'm just reminding you again and again, please do not make that mistake. Because I'm not saying you will make that mistake. Your brain will give you all kind of smart ideas. It's gonna say, I know you've been working hard for so many days, right? Not even days, it's weeks, right? It's not easy. I understand. Nobody else understands you. I do, right? So just relax a little bit. It's okay. Don't fall in that trap. Your brain is real smart. I will try as hard as I can to pull you back. Like, okay, just relax. Just sit in the back seat. I'll drive for you. And you won't find that driver when you need that driver. In the exam, you'll be on auto mode. Right? Those new taxis in San Francisco running, there's no driver. What is called? I forgot their name. What Waymo or something like that, right? You guys heard
Yeah,
about
it's
that?
called Waymo.
Yeah.
Yeah.
So don't find yourself in the backseat of Waymo, okay, and you're just scared like, oh my goodness, am I gonna land safe or not? So drive will keep it in your hand. All right. Okay. Some of you guys did submit your PowerPoints for the presentation, student project presentation. And I don't know if you got a chance to take a look or not. I think couple last night and this morning I did give feedback on those. So if you did submit, please go back and check your submissions there. You'll find some suggestions on my end, and hopefully they'll help you to improve those slides to maximize your grades. Those are due by, and anybody remember the date? Is it like 22nd? Is it due this week?
It's on
I think
Sunday.
it's Sunday.
22nd, yeah. So today's 20th. So I only see few submissions yet, right? I don't see many. Only few, I believe 9. And before the lecture, whatever I saw, I did provide the feedback. I don't know if somebody else may have submitted later on. I'll try to look maybe late tonight or tomorrow morning. But just practically, as I mentioned previously, like as long as you guys submit ahead of time, I should be able to provide you feedback so that you can improve and submit the best version of it. But if I start getting messages tomorrow, day after tomorrow, unfortunately, I won't be able to go over them anymore because that's way too close to go over and then giving you suggestions and then you trying to fix at the last moment. That's not ideal. But if somebody submitted today, I'll try my best to go through as many as I can. Okay, and that was the reason I was telling earlier that try to submit them soon so that I can go over them. Okay, anybody have any question or any help needed in those PowerPoints? And let me check one thing actually for one of the students. Okay, okay, now that actually been corrected. Thank you, Trina, for responding and taking care of that. I will go through that again, okay?
Okay.
Anyone having difficulty developing those or any issues you guys are experiencing? Please make sure it's in the right format and PowerPoint, not any other form, okay? No other file form, just a PowerPoint. And before you submit, go through all the required information listed on your instruction list. Match it that you have everything listed in a clear way. And when you're
Professor,
writing,
sorry, I have a question about the final exam. Is it still going to be 60 questions?
yeah, exactly. I mean, fine. No, I'm sorry. Oh, you know what? No. Final exam is 80 questions.
Professor, real quick, I gotta go. My kid got his finger stuck in one of the tables at the lunch, and
Oh
it's
my
been
goodness.
stuck for like an hour. I gotta go. Bye.
Yeah, please. Yeah, go ahead. Okay. Yeah, Rabia, it's 80 questions. Final exam is 80. All weekly are 60. The only exam which is more is your final exam.
Sounds good. All right,
Okay.
thank you.
You're welcome.
How do you recommend we start studying for the final?
Oh my goodness. Oh my goodness. What are you asking, Arjun?
Never mind, just kidding. I'm going to
Same way. How you been doing? Now, remember what I told you in the first week, that you will find yourself soon that you are ready to prepare for your final exam. And who's going to help you at that time? What did I tell you? Nothing? Just to smile? Come on, answer.
Study guide.
Study guide, which you created, not what you downloaded, correct? So this is what I was talking about. Now, if you add up all the PowerPoints we covered from week 1 until now, I think you're pretty much going to close somewhere between, I don't know, maybe 1,500 to 2,000, somewhere around there, right? Somewhere around there. You'll be close to that 1,500. So that's a lot of slides. There's no way to go through them well, retain, and then hold on to that information. It just doesn't work that way. That's where these study guides, which you develop weekly, comes handy. If you have 25, 30 pages from every week, well, it's not even 250 or 300 pages, which is many times less as compared to your PowerPoints. And then look into your visual aids, your tools you develop, such as mnemonics. Make sure you try to write them down. When you're trying to relax, try to ask yourself, are you able to recall the mnemonic you created for something like for antibiotic classifications or, gram positive, gram negative, their mechanism of action? Try to write them down. Check yourself if you can recall it. And once you're comfortable, yes, I can recall it. Well, then do more and more questions and see, can I apply it now? There are common errors or gaps found are either we are not focusing on the right amount of material. We're trying to learn everything from too much material. We do not narrow down, which makes it hard to retain and understand the information. Number two is that we are not able to recall it. Number three is you're able to recall it, but you're having problem in applying that into the question. These are multiple steps, and you need to evaluate yourself by doing lots and lots of questions. If you know it, you're able to recall, you can apply, that will solidify. If you're not, well, then it tells you that this is where you need to focus more. And if you are not able to answer them correctly, you're having 50-50 and kind of, going back and forth on your choices, that means there is a gap in application. And when you choose more questions, same type, same topic, and you test it again and again on that, then you should have that clarity, better understanding that this is how I look into this question. Sometimes we just don't understand what they're